Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Welcome, everyone, to Talking PAH, Navigating Clinical Challenges Through Case Studies of Complex Scenarios. My name is Ronald Oudiz. I'm a cardiologist at Harbor-UCLA in Southern California, and my co-host joining us today is Dr. Teresa De Marco, who is a professor of medicine at University of California, San Francisco, up in Northern California. Together, we're your hosts, and we're going to try and complete these learning objectives, which include learning and understanding contributing factors to pulmonary arterial hypertension and considerations in the real world, looking at some pathophysiologic mechanisms, some guidelines, and then analysis of some of these case studies that we're going to be presenting to you. We'll have two cases today, two real-world cases. I'll present the first one, complex PAH, and Dr. De Marco will present the second one, disparities in PAH care. So with that, I'll start. Case one is this complex PAH patient. She's a 33-year-old female. We'll go over her history and some of the assessments and some of the treatments sequentially. She's 33 years old. She was diagnosed with lupus and nephritis, and she presented with easy fatigability, which began when she was 7 years old. She was diagnosed finally with lupus at 26 years old after she presented with pericarditis that required pericardiocentesis. And then she was later diagnosed with lupus nephritis when she was 30 with these positive serologies. She didn't respond very well to these disease-modifying therapies. Hold that for a few slides because you'll see where that comes in. She didn't have any allergies. She was employed, married, had no kids. She did have a sister with a family history, and she was not using any drugs or tobacco. She was noted to have dyspnea in rheumatology clinic. She said that she could walk to her car and then got shortness of breath. She could walk about a block, but couldn't make it all the way without stopping. She didn't have any syncope or pre-syncope palpitations, chest pain, or edema. And the rheumatologist appropriately ordered an echocardiogram. And I'll just stop here because when we look at echocardiograms, the real world in an echo lab is that many patients actually have PH, pulmonary hypertension. So if you focus to the right side of your screen, you'll see that PAH, which is our topic today, is actually pretty rare. In the Western world, in the US especially, the most common PH that you will find is that associated with left-sided heart disease. It can either be systolic or diastolic dysfunction or combination. And the next most common, also very frequent, is PH associated with lung disease. We have this idea that CTEPH can also cause PH, and actually groups 1, 3, and 4 all cause precapillary PH. So if you focus on the left, the current definitions hemodynamically of what we call pulmonary hypertension are a mean pressure of greater than 20, and what differentiates pre from post-capillary is the wedge pressure. And so if your wedge is less than or equal to 15, which is actually still a little bit high, even for a non-left heart disease patient, then you are considered to have precapillary PH. And if you have a wedge greater than 15 and your PVR is low, then it's isolated post-capillary. And there's this entity that we don't really know yet what to do about that's combined pre-post. And of course, another one, exercise PH, still not sure what to do about that. But the concept here is back to the right side of your screen. PAH is a diagnosis of exclusion. It's not group 2, not group 3, not group 4. And so just looking at the hemodynamics really isn't enough. So it turns out that this patient had a diagnosis of a secundum ASD, 1.4 centimeter hole between the right and left atria found on 2D echo. Now that's actually relatively small hole, but the RV, the right ventricle, was noted to be moderately dilated and there was moderate TR, but there's no report. And in fact, I couldn't even find a TR jet of an RV systolic pressure on the TTE. The patient then went for transesophageal echo TEE, confirming the small ASD/PFO with an estimated pressure of 54 millimeters of mercury plus right atrial pressure. That's how we estimate PA pressures on echo. We don't have time to go into lots of details on learning about PAH and about echo and about signs and symptoms. This is more of an advanced discussion for those of us that are familiar with PH. Here is an echo, a subcostal view. You can see the liver at the top at 12 o'clock, and you can see that orange color jet across the interatrial septum, right atrium on the top and left atrium on the bottom. So there's a left to right shunt here. The right ventricle doesn't actually look very big in this view, and the left ventricle is contracting normally. We'll just talk a little bit about the idea of shunts and what they do. Generally, I don't believe that, especially at a young age, a small hole in the heart in an ASD position will cause much of any damage to the heart. And the idea of closing it is really for the long term. If the heart is starting to dilate and maybe there's mild pulmonary hypertension, that you might be able to close it. However, what you need to do before you close it is to measure hemodynamics and determine, first of all, that there is a substantial left to right shunt, which will contribute to the patient's morbidity and outcome, or determine whether, in fact, it's not a lot of volume, and therefore, if there is PH, you have to look for alternative causes. So she was sent to cardiology clinic. These are her vitals. She had some interesting exam findings, only trace edema, and a TEE with a bubble was ordered. And here you can see that when you inject bubbles, agitated saline in this case, on the right side, in the venous system, you can actually kind of see, I don't know if I can get a pointer here, where there's a negative contrast across this hole. That's unopacified blood pushing into the right side from the left. So they kind of confirmed that this is a ASD with a left to right shunt, the patient's symptomatic. They said, well, let's refer for cath and possible percutaneous occluder device. Now we don't have to do median sternotomy. We can just put a catheter in the groin and deploy an occluder. So they did the right heart catheterization. I could not find any tracings nor reports of any hemodynamics. However, the atrial septal occluder was placed, and the plan was to follow up in clinic. There was no change in exercise tolerance. The repeat TTE in 1 month post-occluder was ordered just to make sure it was in the right place and there was no leak. That echo showed moderate concentric hypertrophy. The RV was severely enlarged. The RV function was poor. There was severe biatrial enlargement. The occluder was intact. I'll show you a picture there. And there is a TR velocity across the tricuspid valve of 4.8 meters per second and a small pericardial effusion. TR here is how we measure the difference between RV and RA pressure. And the formula is 4V squared if you look to the right. So if you take the TR velocity in meters per second, 4.76 in this case, the computer does it for us. 90 millimeters of mercury was the max pressure gradient. And if you add the RA of an estimated 13, if the IVC was dilated, then you got an estimated PA pressure of 103. Whoppingly high pressure there. Here's what the echo looked at. You can see the artifact from the occluder pointing towards 7 o'clock. You can see there's no leak, there's no shunt right to left or left to right. So the device is working appropriately, but the RV is big and things are not good. So given that PH was found, the patient was referred to my clinic. And in clinic, she's now 34. She reported a lot of edema and ascites requiring paracentesis twice and a lot of diuretics. These were her medications. A lot of them were just PCP related. Some of them were from the rheumatology clinic, but there was a ton of medicines. I couldn't actually assess her CVP. I did note that her P2 was increased, signifying the presence of PH. She had a murmur that was probably a TR murmur. We did PFTs, probably because of her body habitus. Her FEV1 was reduced, but her FEC-DLCO ratio was 0.83. Her DLCO, interestingly, was extremely low at 10% diffusing capacity for carbon monoxide. Here on the ECG, all we really see is the bottom left in lead 3 and the middle top in V1, a little bit of an RSR prime. And we see that sometimes in patients who have ASDs, even without PH. On chest x-ray, this is as good as the film got. You could kind of see that there is a prominent pulmonary vasculature, but you couldn't really look at the pulmonary, whether or not there was pulmonary edema. You could see the pulmonary artery was enlarged, and in fact, the whole cardiac silhouette took up more than half of the chest cavity. I reviewed the right heart cath, as I mentioned before. No hemodynamics were recorded, so we repeated the cath, but this took a while, and by the time we got her in the cath lab, she was already on some PAH therapy. Her pressure was now down to 60/30. Her cardiac output was preserved, but her PVR was pretty high. Her hemoglobin was only 9.7, so anemia was another diagnosis we had here. Doing my due diligence, because we know that group 1 is not 2 and not 3 and not 4, we have to rule out chronic thromboembolic disease, and the best sensitive way to do this is to do a VQ scan. It showed some mismatched defects, And I'll focus in on the bottom left here. This is DTPA. This is the inhalation, and you can see pretty homogeneous distribution of the inhalant. And on the right is MAA, macro aggregated albumin. It's labeled, radio-labeled albumin that gets stuck in the lungs. And you can see at around 7 o'clock on your bottom left of the right lower lobe and right middle, it's eaten up. Again, I don't know if you can see my cursor or not, but it's eaten up over here. And if you compare, that means there's a mismatched defect. The diagnosis we wrote down was precapillary pH, which is true hemodynamically, associated with SLE, maybe questionable CHD, maybe CTEPH. I mean, the VQ scan is very sensitive. It's not that specific. And then, of course, congenital heart disease that's been fixed with an occluder. However, we took away her pop-off. That is to say that if she had severe pH and RV overload, the ability to decompress that RV through a hole now that could go from the right atrium to the left atrium has been removed. Not necessarily a good thing. We plan to continue and add more PAH medicines. We referred her to a CTEPH center since we don't do PTE or BPA here, and we put her on anticoagulation because of that abnormal VQ. We saw her and found that she had been seen at the CTEPH center. She was initially lost to follow-up and then returned to our clinic a year later and returned to them, to the CTEPH center, where they repeated the VQ. And in fact, at the time, it was normal. So on this visit, she was walking well on flat surfaces. She had no dizziness or presyncope or edema. She's now functional class 2. She has really a polypharmacy here that we contributed to by adding this PDE5 and ERA endothelin receptor antagonist on top of all those other medications. And serially, she did well. Then she developed COVID. So now she's positive for COVID. She had flu-like symptoms. Her symptoms were a lot worse. She was starting to heal and get better. Obviously, by the time we were able to see her, she was no longer in confinement, but still symptomatic. She'd gotten to class 3. Now, we, again, don't have a lot of time to talk necessarily about algorithms and go into detail about how to treat and when to treat. We've already sort of passed the risk 3 initial assessment for what to do. We're now in a patient who's at follow-up. And at the bottom here, a little bit on your left, you can see add PRA, prostacyclin receptor agonist. This is one of the bases for why we did what we did to add that prostacyclin receptor agonist. And so what happened with that patient was that she was improved. She had exercise now, ability to go 2 or 3 blocks. She got COVID again. This time she has an echo, and now she's got a large pericardial effusion. So we're kind of stacking all these things on top of each other that can cause shortness of breath and dyspnea and even lead to pulmonary hypertension. We managed conservatively, and we didn't see a need to do anything for diagnostic purposes. We didn't see that she was having trouble and in tamponade, either by echo or by, we didn't do a cath. And we felt fairly confident. And we were right. In this case, the pericardial effusion went away. My guess is it was probably COVID related, and there was maybe some worsening heart failure due to hypoxemia from the COVID. We did another cath, as we often do, now on triple therapy, to just see where we are hemodynamically. As you can see now, we have her PVR down to 3.4 Wood units. In serial follow-up, she was starting to improve again. We did have the follow-up from the CTEPH center. However, here is a 5th stackable for you. She now has the deterioration of that lupus nephritis, and she needs to be on dialysis. She's now had a catheter placed, a temporary catheter, but they want a more permanent solution because she's not going to get better. She needs permanent long-term hemodialysis. So the question comes up, an AV graft or a fistula needs to be put in. And this new problem is that you're going to put in a shunt. You're going to do left to right shunt so that at the hemodialysis unit, you can stick a needle in that shunt or a graft, and you can get enough blood to run through the machine to dialyze 3 times a week. The problem is that RV doesn't always like a new shunt. The original shunt that gets people into trouble, and the reason why we close holes before it's too late, before the PVR is elevated, is to avoid an increase in PVR in an Eisenmenger type syndrome. In this case, we've got a hole that's closed, but we've just effectively created a new hole, or a new shunt, if you will, from left to right. And so the question is what to do. I don't think there's actually a lot published on what to do here. And some of our experts, in fact, that I've talked to have said that they don't come up against this very often, but for some reason we do. And we cringe at the idea that if you put a fistula in that matures to the point of having too much left to right shunt and the RV can't handle that volume overload, you're going to actually make their pH worse. And it's going to be very difficult unless you reduce the shunt or remove it. So my favorite is always just to put in a graft. It's a known quantity. It may not be as ideal for the vascular surgeons or for the nephrologists, but at least you know what you're getting. And with a fistula, you may have a shunt of X amount on day 1, and then on day 365, it might be 2 or 3X. Any comments there, Dr. De Marco?
No, I've never come up with this situation, but it actually makes a lot of sense because you don't want a high flow within the right ventricle that then is presented to a pulmonary vasculature that is already compromised, and you could really elicit a huge pulmonary vascular disease type of response and make the pulmonary hypertension worse, and also issues with the right ventricle will ensue.
Just to summarize then, this is a complex case, and I didn't make it up, and I intentionally chose it because we were, at every corner we did turn, we were faced with new challenges that frustrate our efforts in not only managing PH, but even diagnosing and trying to figure out what is actually going on with these comorbidities. And I love the word distractions that our medical writer came up with. It's challenging decision-making for the clinician at every corner. The clinical response to PH medications is really important. As you saw, we repeated the cath several times. She's had several caths since her initial one for good reason in terms of helping us figure out where she is, what's going on, especially when the original problem had something to do with both left and right-sided hemodynamics. And so finally, this is a real-world case. It's not the only one that we see, that I've seen, that presents with multiple potential etiologies. We have in our hospital a lot of meth use. We have patients who have not only meth use, but they have connective tissue disease. Some even have familial histories that suggest heritable PAH, and trying to figure out where all these are pathophysiologically related can sometimes be difficult. In the case of PAH, the final common pathway, it's more academic in the sense that we can treat PAH regardless of whether it's heritable or meth-related or lupus-related or anything else. A question here, can you elaborate on the most challenging aspects of diagnosing PAH, especially in patients with comorbid conditions like connective tissue disease? Absolutely. Probably the most frustrating differential here in a CTD patient, particularly scleroderma, is the idea is it group 1 or group 3. And you can't tell in the cath lab, they're both precapillary. You have to get a good history. You have to get lung function. You have to get, in other words, PFTs. You have to get imaging. And oftentimes, as a cardiologist, I have to get my pulmonologist involved to decide whether we think this is predominantly hypoxemia-driven vasoconstriction, or in fact, it's precapillary. Teresa, what do you think?
I agree. The other great masquerader is trying to distinguish PAH from heart failure with preserved ejection fraction, especially where the echo findings are not particularly screaming at you with respect to the phenotype. And so the important part for distinguishing those two is really to perform that right heart catheterization, but also take into account the phenotypes, the history, the comorbidities, especially cardiac comorbidities that can confound the diagnosis. And in addition, the right heart is going to be very, very important, again, to make that pre versus post capillary diagnosis. But then even in those cases where the hemodynamics may suggest a precapillary etiology, there are some cases where patients are over-diuresed or they're dehydrated for some reason. They've been NPO, and sometimes the left-sided filling pressure can be lower than expected. And so in those situations, if the phenotype suggests a left-sided problem, in those cases, you can give a volume infusion, about 500 cc's of fluid over a brief period of time, and look at what happens to the wedge pressure. And if the wedge pressure increases to 18 millimeters of mercury or greater, that suggests that maybe we're dealing with a left-sided problem. And then in those situations, you really address your therapies towards the left-sided disease rather than towards the precapillary component that would demand different therapies. So that's another big confounder, and there's a lot of controversy about that one as well.
Maybe I can summarize by saying even the experts don't always know exactly what to do in separating these comorbidities out. Another question that's commonly asked is, what are the early signs of PH that clinicians should be vigilant about to prevent delayed diagnosis? Well, part of the delays are inherent to the patient that doesn't want to present initially because they think either they're out of shape or overweight or something else, and then the physician's failure to recognize. So I think this question is more, what can the physician do to recognize? On exam, an increase in P2 can be a sign that the PA pressure is elevated. It won't tell you what kind of pH it is, but you need to look out for that. Unexplained right heart failure, particularly in a young woman, should always prick up your ears. Now, if you come to me and say, I have a 30-year-old woman with short of breath, the first thing I think about is PAH, but a PCP probably will be correct in saying most cases it's not a 1 in a million disease. Add some connective tissue disease in there, though, and now we're getting up there. Would it be dangerous to tap the effusion in the presence of PH? Do you tap them, Teresa, up there when you have a large
pericarditis? It depends. First order of business when I have an effusion is to do a right heart cath and determine where we are. And also certainly if on the echo there are signs of impending tamponade, one can tap the effusion, but has to be very, very careful. Do it in the cath lab and actually put in a drain and slowly remove the fluid, because otherwise, if it's done too quickly, there have been reports of right ventricular failure and circulatory collapse. So if you are going to tap, you have to be very, very careful and monitor. And usually in those situations, hemodynamic monitoring, as well as tapping with a slow drain and clamping and taking out a little bit more, clamping and taking out a little bit more. But again, you want to be sure that it's for the right reasons, and it's that impending tamponade where you would want to do it. Otherwise, the better part of valor is to treat conservatively, like Ron did in his particular case.
Thank you. Do you find hypoxia commonly in PAH? And once other reasons have been ruled out, what are your treatment options? Well, in PAH, the problem is before you get to the alveolar exchange areas. So other than a very short transit time at very advanced levels of PAH, they shouldn't be hypoxic unless they have a shunt. And sometimes there's a PFO that can pop open when RA exceeds LA pressure. And in those cases, you could do a bubble study and you can see evidence that there's a shunt, and that's why they're hypoxemic. But if they actually have more hypoxemia, you have to first wonder, is the diagnosis correct? Or have you, in fact, maybe uncovered some left-sided pulmonary venous hypertension and there's pulmonary edema? Listen to the lungs, look at the x-ray, decide if there is actually plethora. And then when it comes to patients with ILD, you're again looking for the history, the physical, the imaging, the PFTs. It's certainly possible that you could find a patient that has a little more than mild ILD, severe PH, more than what the ILD could explain, but you're in a gray zone, and it's difficult. And this is why you have to use these medications very carefully and document a response or lack of a response, and then reevaluate what your initial approach was. Every time a patient leaves the room, I wonder if I did the right thing and if I had the right diagnosis.
Yeah, one other point I'd like to make is that there's a condition, pulmonary veno-occlusive disease, where the patients tend to be quite hypoxemic. The DLCO is very low. On imaging, you may see some enhancement of the interalveolar septa. And these are patients in whom treating with the usual vasodilator treatments we use for PAH sometimes can develop pulmonary edema, and then the oxygenation gets worse. And there are cases of patients that don't respond very well to the PH therapies and end up going to lung transplant as well. So this is a particular group of patients that we need to pay attention to, and especially if they're very, very hypoxemic. If it's a run-of-the-mill hypoxemia, what I have found is that you don't get much more VQ mismatch when utilizing the phosphodiesterase 5 inhibitors as the first agents, because they actually are balanced with ventilation and perfusion because they operate through cyclic GNP. And so the VQ mismatch is much less with that particular class of drugs. But it's also noted that we're using prostacyclins, although the VQ mismatch can get worse, by increasing the forward flow, it sort of mitigates that hypoxia. You get increased oxygen delivery. So this is a really important question, but I think if the diagnosis is clear and it's PAH, we should institute our therapies, albeit very, very carefully, as Ron said.
Okay, Teresa, you now have control for case number 2.
This is really going to be about the barriers that are presented to us and how can we overcome some of these barriers to provide optimal care to this challenging patient population. And I'd like to emphasize that the treatment of choice for a patient depends on a variety of factors. There's the objective factors, which are the risk stratification scores, which will guide therapy. There's the objective hemodynamics. There's the RV function on imaging, which obviously will dictate which course of action we take. But we can't forget that there are patient factors, and very importantly, the comorbidities that play a huge role in how the patients respond to the therapies. There's also the age. There's a quality of life issues that may be important to the patient. There's the support system that the patient may or may not have to be able to go forward with these therapies. We also have to consider what the route of delivery is. And again, this is going to be informed, but some of those other factors that are going to be important. And also the side effect profile that the patients are going to exhibit once they're on these therapies. So the treatment choice has to take into account all sorts of factors before we make that decision. And let's not forget, it's always a shared decision process. And there are goals from the provider side. There's also goals from the patient side. And we need to marry those goals to give the appropriate individualized care to the patient. So here's our case. It's a lovely 63-year-old woman, and we'll go through the assessment for the diagnosis and management. So she's a 63-year-old African-American woman with comorbidities. She has a history of high blood pressure, type 2 diabetes mellitus, which is currently diet control. She's obese, and she also has a prior history of stimulant use disorder with methamphetamines, but she also presents with hand arthritis. She has been experiencing progressive dyspnea for the past 8 to 12 months. But when she presents, she can only walk less than 2 blocks on level ground and less than 1 flight of stairs. So she's in the class 3 functional capacity symptom complex. But she is able to do her activities of daily living. She can do her chores. She can shower, and she can dress herself. But she does note some swelling in her legs. So medication-wise, she's not on any currently. In the past, she had been on antihypertensives, and she had also been on oral medications for diabetes. Socially, she does not work, and she lives in a rural area with her daughter, who happens to work 2 jobs, and she does not have a car. She has a history of prior methamphetamine use, but is now abstinent for several years. And she used to smoke, but stopped about 10 years ago. She has Medicaid insurance, and she really does not follow with a PCP. There's a paucity of PCPs in her area, and also not many of them that accept Medicaid. So she's in a bit of a pickle here. So she has to present to the local emergency department for these worsening symptoms. That's her only recourse. On presentation, she's hypertensive. Her oxygen saturation is 91%. It's on the lower side. She's obese. Her lungs are clear. So it doesn't suggest to us that she may have a left-sided problem at this point yet. They do a physical exam, and they did not document jugular venous pressure. And, it is difficult to assess the JVP, especially if the body habitus is on the high side. The abdomen was possibly distended, but again, it was globose, so they couldn't tell what was going on. The extremities did reveal significant edema. She did not have any clubbing. And then on laboratory studies, her creatinine was elevated and her BNP was elevated to 252 picograms per milliliters. So in the emergency department, she was treated with 20 milligrams of IV furosemide, and she had a brisk diuresis because she hadn't been on diuretics prior to that. And she felt a little better, so she was sent home with a prescription for hydrochlorothiazide for her hypertension and to deal with the edema. And then she was told to follow up with a PCP. Easier said than done. So she feels a bit better. With the hydrochlorothiazide, she has less swelling, but she really can't secure a follow-up with a primary care provider and quickly runs out of medications after a month. Nothing is happening. She's lost to follow-up in essence. And over the next 6 months, her symptoms progressively worsened. She is dyspneic to less than 1 block on level ground. And sometimes, even with her activities of daily living, she notes worsening swelling in her legs, and she has increased abdominal girth. Her weight has gone up by about 15 pounds. So her only recourse, she represents to the local county ED, and which happens to be impacted as most county EDs are. And in the emergency department, she waits 6 hours to be seen. Ronald was telling me that in some EDs, it can be up to 16 hours, and then the patients wait there and wait and leave against medical advice because they're not being taken care of. So that's another problem that our patients face. So then on physical exam, we see that this time her blood pressure is lower. She's quite tachycardic. She's tachypneic. Her respiratory rate is high. Her oxygen saturation is less than 90, and her weight has gone up by about 15 pounds. Her lungs continue to be clear, but she has increased respiratory effort. On physical exam, now the emergency room physician clearly sees neck veins that are elevated to the angle of the jaw, and he palpates her heart, and she has a left parasternal lift, which could suggest either an enlarged right ventricle with poor systolic function or an enlarged left atrium, which is pushing the right ventricle forward, giving that left parasternal lift. She has a systolic murmur that's very loud at the lower left sternal border. There's no mention about the P2. There's no mention about a gallop at this time. So on an abdominal exam, it is obese. It appears distended. But what's interesting, and the astute ED physician picked up, is that her liver feels enlarged, and it's pulsatile, which is congruous with that holosystolic murmur. So a pulsatile liver is indicative of significant tricuspid regurgitation. On exam of the extremities, she has 3+ edema now. She doesn't have much in the way of clubbing. There may be some cyanosis, and it depends on what her oxygen saturation is at the time. And she does have these joint deformities in her hand. Okay, so as Ron described before, what are the early signs of patients with PAH? Well, cyanosis, but that's pretty advanced, and usually there's particular conditions that lead to that. And then that very important accentuated pulmonary component of the second heart sound. So the second heart sound is comprised of closure of the aortic valve followed by closure of the pulmonic valve. And in the normal situation, the closure of the aortic valve is louder than the closure of the pulmonic valve because it's at higher pressure, and there's a very short hangout time. So it's a very snappy closure. So if you were to listen at the lower left sternal border or at the apex, and it happens that the P2 component is of equal intensity as the A2, you're talking about a pulmonary artery systolic pressure greater than 40 in the order of about 50 millimeters of mercury. If, however, the P2 component is louder than the A2, you're dealing with a PA systolic pressure that is in the systemic range. And so that is consistent with significant pulmonary hypertension. The problem with this particular sign, it really requires a trained ear to pick it up. It's a very difficult sign. In addition, there could be a third heart sound, and a third sound, heart sound is indicative of high right ventricular and diastolic pressure, either from diastolic dysfunction, but usually systolic dysfunction when it's the third heart sound. When it's the fourth, it may be more diastolic dysfunction. And then you have the systolic murmur of tricuspid regurgitation, which is common, as we described earlier. And if you have a diastolic murmur of pulmonary regurgitation, that does indicate pulmonary hypertension. Then you can look for signs pointing towards underlying causes of PAH. A digital clubbing is associated with hypoxic state. There auscultatory findings of the lungs and the heart, crackles or wheezing, any murmurs will lead us to suspect a certain etiology. Sequelae of a DVD, such as a venous insufficiency, can point us towards chronic thromboembolic PH. Telangiectasia can be associated with hereditary hemorrhagic telangiectasia or connective tissue diseases, especially scleroderma. And then if you have sclerodactyly, Raynaud's phenomenon, digital ulceration, gastroesophageal reflux disease, all of these can point towards a connective tissue disorder, especially the scleroderma spectrum of diseases. And then the signs of right heart failure, which are common when patients present because there's a delayed diagnosis. You can see the distended neck veins, abdominal distension, hepatomegaly, ascites, edema, and then the signs of hypoperfusion, low output state, the cyanosis, the dizziness, mental obtundation, cool extremities, and prolonged capillary refill do suggest reduced perfusion. So with our lady, obviously, laboratory studies were done. Of note, she has a borderline low sodium, maybe due to heart failure. She has an elevated creatinine. It's gone from 1.4 to 1.7, which may reflect renal venous congestion or some element of hypoperfusion. Her glucose is now elevated to 318, and so she has a significant hyperglycemia that needs to be attended to, and her BNP has gone from the 250 range to 805, which is markedly elevated. Her TSH is normal, and her total bilirubin is in the upper limits of normal. So other labs were done. Her troponin was borderline, but it doesn't rise. Her liver transaminases are normal. Her HIV serologies are negative, and importantly, her urine tox screen is negative, supporting the fact that she's been abstinent. Her arterial blood gas showed a PO2 that was less than 60, but on chest x-ray, she had clear lung fields, a large cardiac silhouette, and on a large RV lateral view, which I'll show you in a bit. And then her electrocardiograms show sinus tachycardia with PSC. She has right axis deviation and right ventricular hypertrophy with a tall R and lead V1 and S waves in the lateral leads. And she has anterior T wave inversions, which are suggestive of RV strain. So here's her chest x-ray. And what we see is enlarged main and hilar pulmonary artery shadows. We can see a prominent right atrium, some pruning of peripheral pulmonary vasculature, which is really difficult to see in this particular chest x-ray. But then on the lateral, you see a filling in of the retrosternal space consistent with right ventricular enlargement. So in the emergency department, she gets oxygen, her SpO2 increases, she gets diuretics, she feels slightly better, she has a fantastic diuresis, but she needs to be admitted because she's in serious trouble here. She's admitted to the hospital service and she receives more diuresis some more, and then the hospitalist gets consult from cardiology and pulmonary at the hospital. They suggest doing serologic studies, and there's no evidence of connective tissue disease, and she doesn't have anything to suggest that. So her joint deformities were osteoarthritis. Then she has an echocardiogram done that I will describe, but she does have an estimated PA systolic pressure of 90 millimeters of mercury and an elevated right atrial pressure of 15 millimeters of mercury, which jives with the jugular venous pressure on exam. They do their due diligence, do a VQ scan, which is low probability, no mismatch ventilation perfusion defects. The spirometry is normal for her age. The DLCO is 50% of a predicted. It's lower, but not less than 45. That would suggest maybe some pulmonary issue. And they also did a chest CT, and there was no parenchymal lung disease. And here's her echocardiogram. And on the left screen is the parasternal long axis view, and the right ventricle is up at the top. The left ventricle is at the bottom of the screen. And basically, you see a markedly enlarged right ventricle and a small underfilled left ventricle. Then we look at the parasternal short axis view, which gives you a really good look at the septum. And what you can see, again, this very large right ventricle impinging on the left ventricle, and you have a shift of the septum towards the left ventricle, and this shift occurs both in systole and diastole. When it occurs in systole, it suggests pressure overload. In diastole, it suggests volume overload, but in this case, it's occurring throughout the cardiac cycle. So you have both pressure and volume overload, and perhaps it's that tricuspid regurgitation that's giving you that appearance as well, in addition to the high PA pressures. And a picture's worth 1,000 words, and that 4-chamber view on the right side shows us the right-sided chambers, which are markedly enlarged, and the left-sided chambers, which are small and underfilled. So left ventricular, left atrial compliance is reduced, and the left-sided chambers are starved of adequate preload, which then translates to a poor systemic cardiac output. And the end stages of pulmonary arterial hypertension is the inability to fill the left ventricle. And then that's when the patients can go into cardiogenic shock. And the cardiology consultant is very astute. So he or she orders a right and left heart catheterization while the patient is undergoing diuresis. They do a coronary angiogram, and I would do the same. Our lady has risk factors for coronary artery disease. She has diabetes mellitus. She has hypertension. She's obese. And reassuringly, there's no obstructive CAD, but she has luminal irregularities in the beginning of non-obstructive disease that does merit attention. Her hemodynamics, she has a right atrial pressure of 10, so it sounds like maybe things have gotten better with the diuresis. Her mean PA pressure is 50. It's greater than 20. That's concerning. It's severe pulmonary, precapillary pulmonary hypertension, since the pulmonary arterial wedge pressure is 13, and she should probably be diuresed a bit more. Concerning are the cardiac index of 1.8 liters per minute and the pulmonary vascular resistance of 9.5 Wood units, significantly greater than that 2 cutoff. And they did vasoreactivity testing with adenosine that didn't have nitric oxide, and they were looking for a fall in the mean PA pressure by 10 millimeters of mercury to the point that it would get to less than 40 without a reduction in cardiac output. But this is advanced disease. The vasoreactivity study was negative, and so calcium channel blockers are not in therapies to start. In addition, she has low output state. You would never think of giving a calcium channel blocker in this woman. So the diagnosis is precapillary pulmonary hypertension with from PAH associated with the prior methamphetamine use. And she also has some comorbidities, hypertension, diabetes, and obesity, which are not really driving the pulmonary hypertension. So we really do need to not only address the comorbidities, but really direct our attention to the PAH. So diuresis is continued. They discussed going to a PH center, but it's 152 miles away. She has high risk parameters. And in the best of all worlds, certainly in addition to other therapies, parenteral prostanoids would be indicated. But this local hospital cannot administer it. So they discussed the situation with the patient. She really did not want to transfer to the PH center. She had poor resources and her family situation with her daughter, inability to visit her, so she declined. So at that point, with the help of the PH center, the hospitalist was advised to start sildenafil. And then when she was fully diuresed at her dry weight, the decision was made to also add an endothelin receptor antagonist, macitentan. And it required a lot of help from the PH center to put these in place. It took 4 weeks to optimize her and get these therapies in place. And then the case management team that was available was involved, and they tried to obtain outpatient follow-up for her. And where things kind of fall apart a lot of times is that transition from the inpatient to the outpatient, especially with those patients who have some psychosocial or care disparities barriers. All right, so the ESC-ERS guidelines recommend regular assessment using the multi-parametric risk tools. And it doesn't matter what risk assessment you use. There is a website, the Pulmonary Arterial Hypertension Initiative risk calculator, that you can download and actually plug in some of these parameters to get a sense of what the risk profile of the patient is. But then it's really clinical judgment. We have to take into account all those confounding issues and patient factors before we have a decision of what to do. And never forget that it's a shared decision making process. But we have to be expeditious as we can, because PAH progression can occur rapidly and even in early disease. So as aggressive as we can, despite these factors. So the patient was discharged on oxygen, upfront dual combination therapy. She was also sent home on general measures, diuretics, spironolactone. She was also given digoxin because of her low cardiac output. She was put on sub-Q insulin with the plan to probably start an SGLT2 inhibitor as an outpatient, and atorvastatin because of her luminal irregularities and some non-obstructive coronary artery disease. The plan was to follow up with local cardiology and do video visits with the PH center, which was in state. And that was certainly a possibility, and that was arranged. They couldn't get a PCP appointment. That's always so difficult, especially in a rural setting where there's a shortage of primary care providers. But despite dual upfront therapy, she continues to deteriorate. She becomes dyspneic arrest. She has signs and symptoms of worsening heart failure. And she does not have transportation or support resources to go to the PH center. So here she goes again into an emergency room, now via ambulance, and she's in cardiogenic shock due to right heart failure. So everybody descends on her. She goes to an ICU. She's treated with norepinephrine, dobutamine, diuresis, high flow oxygen. In the ICU, she stabilizes, and finally, she understands what the issues are and how life-threatening this is, and agrees to transfer to the PH center, and will deal with the other issues later. So at the PH center, she's initiated on parenteral prostacycline, sub-Q treprostinil. Her volume status is optimized with diuretics and judicious volume removal. The dobutamine and norepinephrine are finally and slowly weaned off. She continues on supplemental oxygen, but it's now down to 2 liters per minute. And important, during this hospitalization, she gets a lot of education from the PH coordinators, clinical nurse specialist. The PH center social worker comes into gear with the case managers, and they work really hard to identify an additional caregiver, which is a church member who the patient knows and even considers a friend. And she lives near the patient and happens to have a car. Hallelujah. So then the patient's daughter and the church friend, they're trained on subacute treprostinil along with the patient. The social worker helps the patient along with the financial counselors to initiate disability paperwork. So the patient is then discharged with close local follow-up, the local cardiologist. They finally are able to secure a primary care provider, and the PH center follows her up with video visits and directs the frequency of the studies, which are going to be a BNP, a 6-minute walk test as best that can be done, and regular echoes. And also the patient is given a lot of support. She participates in remote support group activities, which are so essential to provide that touch from other PH patients, and so that the patient doesn't feel alienated or alone, and has that support from her peers. She eventually receives disability, which really helps a lot in her financial status, and also Medicare, additional support. So she improves symptomatically, but is still in an intermediate high risk category. And so the PH Center pursues enrollment in a new therapy, subcutaneous sotatercept, which has been shown to improve exercise capacity, delay time to clinical worsening. And in the event that patient doesn't respond, and now that her psychosocial situation has been improved, there will be consideration for lung transplant candidacy down the line. And what I'm showing here is just one of the risk models, the Compara 4-strata risk models. And this risk model will segregate the patients into low risk, where the 1-year mortality rate is up to 3%. Then you have the high risk strata, where the mortality within 1 year is greater than 20%. And then you have the intermediate risk, the low versus the high risk. And it's all based on the functional class, easy to attain, 6-minute walk test, but it has to be done correctly using ATS guidelines. And then biomarkers, whatever you have, BNP and NT-proBNP. And using that calculator that I mentioned earlier at the PAH Initiative website, you can assign the risk profile of the patient. And in those patients that are intermediate, high, or high risk, our patient was initially high risk, and she's already on subcutaneous prostacyclin analog. And in this situation, one can consider adding sotatercept. So I'm going to conclude with the following points. We know that there are multiple PAH treatments for our patients. PAH can be a rapidly progressive disease, so we have to be very aggressive as we institute these therapies. But the treatment strategy has to be individualized, depending on patient factors. And it has to include the management of comorbidities, because with these comorbidities, the patients may not respond as well. And also, there's a higher side effect profile. So we have to be particularly careful when there's comorbidities associated with the PAH. And the goal in most of our patients is to achieve and maintain a low-risk status, if attainable. It's harder to maintain in those patients with associated comorbidities. And then finally, the psychosocial barriers, the care disparities, do delay or prevent optimal care. And because the optimal care is delayed, the outcomes are also worse. But how can we overcome these disparities? Well, it's essential to have a multidisciplinary approach. And then the co-management strategies with our local partners is going to be very important in helping our patients overcome these barriers. So I'm going to go ahead and stop here And we'll review some of the other questions that have come through the chat. So let me see. One of the questions is, how do racial and ethnic disparities impact the long-term outcomes of PAH treatment? And what strategies can clinicians adopt to mitigate these disparities? Well, like I explained, you just have to understand, number one, that these disparities exist. And to mitigate them, we have to provide that support, and we have to work extra hard with our multidisciplinary team members to see how we can overcome these and provide that support to our patients on an intimate basis in an individualized model. So I think we understand that the overall outcomes are going to be worse than in those patients who don't have the disparities. But it's incumbent upon us to put the full force of our team to sort of equalize those disparities. And there's going to be a lot of work that our social workers do, our financial counselors, our case management, our pharmacists, the whole team, to be able to assist and provide that support to these populations. Do you have anything else to add, Ron? Which I think I'd like to hear from you, because you come from a safety net hospital and you have a lot of experience with these issues.
Well, I think first and foremost, the outcomes are worse. And so in a sense, they're higher risk right off the bat. And when we try to assess the in-home support and the community support, it really does impact on what we do for treatment. Unfortunately, some of our more potent treatments are also those that require more home and community support. Luckily, with our field, and the specialty pharmacies do quite a big job of cleaning up after us, in the sense that they'll visit the patient's home. They'll often email or text me what the conditions are like at home and what the likelihood of long-term successes are. So that's one way that we exploit the availability of those specialty nurses. Another way is with support groups, but for your patient that's rural, they not only have a challenge from the disparities that they have, but they also have the distance disparity. And there probably aren't half a dozen or 20 or more individuals in their immediate area that they can go network with. So now we have Zoom that's shrunk some of this distance barrier, at least from the interaction. But I find a lot of these patients are really hesitant to jump in and initiate. So we kind of have to push them and tell them, trust me, you want to do this. You want to engage with others, even though it might seem distasteful to try and remind yourself that you have this disease. It's actually beneficial for them to see that others are just like them.
And I think we're done. And thank you, everyone. Thank you so much for your attention.
Thanks, Teresa. Bye, everybody.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.